that? I'm missing one. Is there anything? Okay, so we're going to start with some pigmented things now. So seborrheic keratosis, there's that word again, seborrheic. It means oily. Keratosis means excessive keratin production. So that seborrheic keratosis, here are pictures of them. And they actually can be anywhere from lightish tan, yellowy color, all the way to dark brown black. And it's those darker brown black ones that really concern people, thinking they're true moles that potentially go to cancer. Well, seborrheic keratosis are benign growths in adulthood. It lets you know you're over age 30. And thank your parents for them, because they tend to grow, you know, you find them in families, and the number you get or how big they are tends to relate to what your family history. So look at your parents and see if they have some, and then it may determine kind of where your skin's headed. But it's an epidermal process, and many times in dermatology we like to know if things are happening in the dermis or the epidermis. How do you know the difference? By just looking. If things are rough, scaly, like psoriasis, or eczema, right? Atopic dermatitis is scaly, seborrheic dermatitis was scaly. This is warty-like, kind of crumbly and crusty. They feel like they're stuck onto the surface of the skin. All of that means it's happening in the epidermis. The stratum corneum, the upper layer of the skin, remember, that's the first layer, that's the dead layer, that's the keratin layer that is disturbed. In this area, you got hyperkeratosis, very thickened, heaped up stratum corneum, but the process is happening in the epidermis. Not only excess keratin on top of in the stratum corneum, but the rest of the layers of the epidermis are thicker. The inflammation in psoriasis and the plaques are forming in the epidermis, with the flaking happening and thickening of the skin. Okay, same way with atopic dermatitis. This thing, even though it looks raised and very thick, it doesn't mean it's deep. This is dead skin, stratum corneum, stuck and heaped up on top of each other, and many times they can start on a browning, what people call liver spot or age spot. So a lot of people feel that it is a continuum of a brown and age spot that over time develops a little scale and crust and starts to build up over time. Although these are not seen always in sun-exposed regions. These can be on the back, on the legs, in the pubic area, in the scalp. So there is some of a genetic predisposition for these. Okay? So the stuck-on, hyperkeratotic nature, those are like buzzwords for seborrheic keratoses. They do not have cancer potential at all. Reassurance is what we give people. People of color get them too, but they tend to be more pigmented, darker in nature, and a lot of people call them their flesh moles, but there is a special term in people of color called dermatosis papulosa nigrans, and DPNs, also known as what we lovingly term the Morgan Freeman look. Okay, that's what he has. He's got pigmented seborrheic keratosis. I'm like, come to me, I can get those removed. But anyway, you find them on their cheeks. You know, a lot of times they're on their neck, and sometimes they can be pedunculated, meaning there's a little stalk that makes them hang. So they mimic skin tags as well. But we don't, in people of color, we have to be careful how we remove them. In Caucasians, we can do just freezing of liquid nitrogen and, you know, blister up. It may take about a couple weeks, but the whole thickened crust will just slough off. Sometimes you have to do it more than once. But many times I'll do this in people of color that want them gone, and I numb them up with a numbing cream of beta-caine, tetracaine, and lidocaine. And we apply that cream on them, let them sit for about 15 minutes and remove it. And then I'll use a very fine scissor and just scissor them off because they're just on the surface of the skin, and I just kind of get underneath there and scissor them off. There's usually a little lighter pink pigment of their skin there, and so when they heal, because I've disturbed their pigment a little bit, it may hyperpigment, then I give them a fade cream to even out their skin again. I don't like to do freezing here as it causes cryosurgery. In people of color, freezing stuns the pigment cells. It will make a true white spot, almost like vitiligo in those areas. So we don't do a lot of freezings on the faces of people of color. Now, if it's something on the back and they don't really care, they just want it gone, we might do that. But on the face, you have to just be very cautious and warn them, hey, freezing on the face, you're going to potentially leave a light spot. It may or may not repigment. Okay. So here's someone that I did, a couple of them. You see this lady that has little small ones around her cheeks, and this is her immediately afterwards. And she's a little red, maybe a little puffy there, but it healed really nicely. Here's another one. See this lady? All the little ones she's had. This is immediately afterwards. You can see she's kind of red, and a few maybe little light spots in there. But it takes a good 2 to 3 weeks for them to kind of get rid of all the redness and inflammation. And I might give them, especially the people of color, a fade cream. But it looks good. It looks even. All right, let's talk about other brown things. Melanocytic nevi. So there's 3 kinds of benign nevi that, I guess the classic kind if you want to call it. Junctional type, compound, and intradermal. And it basically, the naming of these moles, if you want to call them, are based on where the clusters of pigment cells are nested. So look on your skin. Do you have a little dark spot that's just a flat pigmented spot? Don't get that mixed up with a freckle. But something that's very dark, maybe in solitary, very well circumscribed. All right, that's flat. It's not elevated. That's a junctional nevus. And that means the clusters or the nests of pigment cells are layered, deposited at where the epidermis and the dermis meet. And they call that the dermoepidermal junction. Dermoepidermal junction. So that little section in between the epidermis and the dermis kind of obscures a little bit of the baseline there. That's where these junctional pigmented nests are. And so when it's just lining the dermoepidermal junction, these clusters of pigment cells, it does not elevate the skin. It's just flat. So many people find that they have all these little flat, brown, circular moles that are well circumscribed. Okay? Now, moles can go through different phases, and they can start to raise up. They can initially be flat, and they can raise up off the surface of the skin. And what in the world made them rise up? They still have the junctional part that they started with, but they now have developed pigment cells nested and clustered in the true dermis now. So now you have a junctional nested area and a dermal nested area. The two of those together is what the dermal part makes it raise up. And we call that compound nevi, or compound nevus. 2 components now. Does that make sense? So if you have a raised brown mole on your body, we call it a compound nevus. Okay? And we already know by feeling it and seeing it where the clusters of the pigment cells lie, both junctional and dermal. Okay? Now, as people get older, also, I say, some of the moles that people develop, because there are some moles that are run in the family. You may have the same mole mom has or grandma or something. And those are usually on the face, you know, a flesh mole that's just the color of your skin, may have a little hair growing out of it or something. Those many times are non-pigmented, right? So over time, moles will lose their pigment and realize it's that junctional part that lets you see the pigment. I mean, is what gives rise to the pigment of the mole. So over time, the junctional part will remove or go away, and you still have this dermal clusters left. That's what the intradermal nevus is. So when you just see it's the dermal part, remember, that makes it rise up. It's still there, but there's no pigment with it. So that's letting you know there's no junctional portion. So it's all intradermal. And that's what we call an intradermal nevus. So by looking at moles that are just benign and normal, I can tell you if it's junctional, if it's black, right? If it's brown and raised, that's compound. Or if it's just flesh colored, that's what's called an intradermal nevus. And as long as they're well circumscribed, even in the color, no jagged edges or borders. We like our moles the size of a pencil eraser. And these are the ones that are usually acquired through life. You never see a moley baby full of spots and dots, and speckles and freckles. So the vast majority of our moles are acquired through life. There are some moles little kids are born with. They call them their birthmark, big brown patch somewhere. They have some hairs growing in it. And so, yeah, those tend to be larger than a pencil-size eraser. So we look at the rest of the characteristics of it and make sure that it's even throughout, colors, symmetrical, and all of that. So there's your 3 major melanocytic nevi that we look at and recognize as we do mole checks. And this is just a little graphic on where those where melanocytes are in the basal layer. But then they will drop down right here at the junction and cluster up as new moles are made through life. And you will continue to make new moles up to 40 and 50 years of age. So we do know that the acquired moles, especially the ones that are pigmented, tend to be sun-related. So if you notice that on your arms, all your brown speckles and moles, little tiny moles, are on the extensor surface where the sun hits. You flip over in your inner arm, it's just as clear as can be, maybe even a little lighter tone, because that's been protected away from the sun. So yes, new moles activated from the sun is well documented. So here again we're just going to break down junctional. Do you see that's flat? It is actually kind of undulating with the markings of the skin. See that? And that's a common feature of junctional nevi. Do you see these nests down here? See these little clusters? Those are a lot of pigment cells in there. This is what a junctional nevus, if we biopsied one of those, what that looks like. Right at the junction, it abuts the epidermis and immediately found right there in the dermis, okay? Compound. And sometimes these can get you confused with those seborrheic keratoses because they're brown. Sometimes they have a little invaginations in them. But they're medium brown, variation of in their elevation. But it is both junctional and a deeper dermal portion, right? So you have some that are junctional at the top, right at the junction, and then some dropping down directly into the pink dermis. Okay? Got that? Now, what happens when you just have all intradermal? Do you see any brown or little blue nests at the junction up here in our pathology? No. It's all clustered in the dermis, all these nests. And that is what we see when you just have a pink flesh mole elevated. That's called an intradermal nevus. All right, Now, what starts to happen if moles either begin to change, or maybe it starts off as atypical, what we know as dysplastic nevi. It starts to not become well demarcated anymore, well circumscribed. They start to get a little hazy around the edges. The borders are not maybe as distinct, irregular maybe in the coloring, size and shape. Many times it's multiple. And I've seen this like on guys who've gone without a shirt, you know, in their teenage years, and they've had sunburns, and they might have some larger, just irregular reddish brown moles on their back. And we have to really look at those to make sure that they're still okay. Dysplastic nevi of themselves do not equate to cancer or melanoma, okay? They have some feature changes, but do not have all the characteristics of melanoma. So it's not like you have to keep cutting all of them off. But we usually see them on the trunk, extremities, buttock, groin, breast. Now they can sporadically come up, and usually from the sun, and it has a slight increased risk of melanoma. But if this can be genetic, there are families that have familial atypical dysplastic nevus, it's the syndrome as they call it. That is extremely a lot higher risk for melanoma. So many times we'll see the full family and see if they also have the atypical nevi that have to be watched and photographed and checked by biopsy. So melanocytic nevus treatment. So if for regular moles, we reassure patients, right? If they become irritated, especially the intradermal or the compound nevi, sometimes they get rubbed. We just removed one yesterday on a lady where it was rubbing where her the seat belt was coming across her neck and getting irritated. And so that's a good reason to remove those. It's also important to remind patients of the ABCDs of melanoma. And as you know, A stands for asymmetry. So if you can cut your mole in half and fold it over equally, whether it's vertical or transverse, that's good. Both in size, shape, the coloring is equal on both sides. It's symmetrical. Borders are regular. We like smooth, rounded borders, but if it starts to get undulated and notched out and this and that, angulated, it's not a good sign. That's letting us know that the little pigment cell clusters are starting to mutate. They're not working together. Some are doing this, some are doing this over here. Color variegation, same mutation, something's happening. That's not good. And our diameter, if it's greater than a centimeter, it's greater than 6 millimeters, or the size of greater than the size of a pencil eraser, we have to start looking at their features of it. Elevation or evolution, did it start flat? Did it start raising up? Is it starting to ulcerate? Is it getting bigger rapidly? That's something we need to look at. And if you think there needs to be a biopsy, you know, you could definitely refer to dermatology for that thing, because we try to get a little bit of margin around them. Sometimes we go ahead and cut them out with actually scalpel, but if we can do what we call a deep shave, we'll try to do that and not have to put stitches and send that for biopsy. So other brown spots that people get mixed up with moles. So freckles, okay? They're pigmented, yep, but they are not moles. The medical word for freckles is ephyllides. So if you have freckles on your face, you have ephyllides. And an ephylid is the singular term for it, for one. But they're light brown macules, sun-exposed region, hands, dorsal hands, face, arms, and they're small little macules, less than 4 millimeters. Irregular borders, but they're uniform pigment. And it just means that you've increased your melanin in the dermis. There's not true pigment cells that have increased in number. You've activated the pigment cells that are already there and made more melanin. They produce more melanin, and now that's deposited in the keratinocytes, epidermal cells. That's all that it is, melanized keratinocytes, extra melanin. That's why when you're in wintertime, they tend to fade a little bit, they're not as dark. You're not outdoors in the sun and you've not activated them from the ultraviolet light, the pigment cells. During the summers, like many children, the little freckles turn darker. Okay? These are not cancerous. It just gives us a clue of how much sun a person has had. So you had to activate them. Now, how do people tell the difference between age spots? Also known as solar, which means sun, lentigo. People call them liver spots as well. So what's the difference between that freckle and the age spot? Well, they're usually bigger, right? And they usually are found in, they can appear at age 20s if a person's out there in the sun a lot, but it's usually older people, right? You see the back of hands of maybe your parents or grandparents. Face, you see big brown patches there. But a couple of things that are found in it. Not only is it increased melanin like a freckle, but there's more melanocytes. That means there's more pigment cells that have been produced from the sun, and it is those excess pigment cells that are there that are not clustered, it's not a mole. These are just kind of singly in there, increased in number. That's what makes them stay. So in other words, age spots stay year-round. And they're bigger than the 4 millimeters usually. They're a little larger in size. They stay year-round. They are benign, but people want them gone. So sometimes we'll freeze them with liquid nitrogen. This is all cosmetic though. They would have to pay out of pocket for it. Liquid nitrogen, or maybe use a fading cream. Hydroquinone is the main fading ingredient we use a lot to lighten dark spots. And so, or lasers and lights as well can be used. So you've seen these on people. They are there, and the windows of the car, especially the left side, is more exposed to ultraviolet light for those outdoors. And so we see a lot more sun browning spots, those solar lentigines, on the left side of the face more than the right. Left arm in the window usually has more actinic damage, as we call it, than the right side. All right, again, the ABCDs of melanoma. We talked about asymmetry, right, for A. So look at our nice mole over here. Very well circumscribed, even in the coloring. And then here, you can definitely cut it in half and both sides be equal. Can you cut this in half and the shapes be equal? Not on this one. So it's asymmetric, where when the half of the mole does not match the other half. Okay, what about the borders? Okay, nice smooth borders over here. Okay, look how jagged and notched out these borders are. Not good. All right, so they are ragged or irregular, so borders for B. Color, variation in color. So it's okay that a mole is completely dark. It's more, is there blue, black, red, brown, gray, smudged, all in the same spot. So you have a dark spot. Probably it probably was brown, and then this darker portion came above. So that's not good. And then, what's the diameter? So is it larger than a pencil size eraser? So things that are larger, we have to look at those and be more concerned about its malignant nature. We have gone through the whole gamut of acneiform eruptions, scaly, eczematous, and other scaly rash eruptions. We have gone through benign moles, malignant lesions, and how they can be distinguished from their clinical, aka morphologic features. What are some diagnostic tools that can be used to determine what things are? How to discriminate between lookalikes. And we talked about certain treatments for diseases, how to find cheaper things for your patients, that are maybe paying out of pocket, and some of the side effects of some of the medicines. And we are done. Any questions or anything that you would like to ask that I didn't cover, or comments on anything? It's a lot to absorb, but you have my lecture that, are you all following along with your own laptop? So you have it to review. And, you know, at your stage, you're having other lectures as well, correct, with regards to dermatologic things? But these are some of the things that you might be tested upon. Of course, hopefully the other things will be covered as well. But this is a good foundation for you, and thank you. Enjoyed it.